Hi, I'm Joni Taylor, head women's basketball coach here at Texas A&M, and I'd like to welcome you to the 13th annual Hilliard discussion brought to you by the Huffines Institute for Sports Medicine and Human Performance. Tonight's topic is not only important for student athletes, but also for military personnel, first responders, weekend warriors, and the average person. We're going to hear from 5 different practitioners on recovery modalities. They're going to cover everything from cryotherapy, shockwave therapy, to your tried and true techniques. HD13 will then talk to us about how and when to use these techniques. It is our hope that you're very active at the end of this segment in the question and answer portion. Again, welcome to tonight's discussion, and I will now turn it over to Dr. Jenna Yentis, who is the Acting Director for the Huffines Institute for Sports Medicine and Human Performance.
Thank you, Coach Taylor. Howdy. It is my pleasure to welcome you to our first Hilliard discussion in hybrid format since the pandemic. As Coach Taylor said, my name is Dr. Jenny Yentis. I'm the Interim Director of the Huffines Institute for Sports Medicine and Human Performance. More importantly, I'm your host tonight. Hilliard discussion is really important to the Huffines, and the reason for that is it's one piece of our mission to really keep that dialogue going between practitioners, sports scientists, the general public, and researchers. HD was first offered in 2011, and since then it's had a lot of different formats. It's had 8 speakers over half a day, and during the pandemic we tried pro-con debates. Tonight, all of our speakers, all practitioners, are going to be talking on one common theme. They've all curated talks that are understandable to the general public, and they're going to talk about recovery modalities, as Coach Taylor said. They're going to talk about all kinds of different methods, each one of them with their own flair. So I know you're anxious for us to get to our speakers, but I want to give you a little information about the general format. Each speaker is going to come out and give a talk, short talk, and that'll take about an hour to get through our 5 speakers. At the end of that, we'll have a Q&A session, so stay for that. And then if you're in person, join us in the lobby for a meet and greet after. All right. Let's get started. Our first speaker tonight is Dr. Heather Linden of the UFC. At the UFC, she is the Senior Director of Physical Therapy, and she oversees the UFC Performance Institutes in China, Mexico, and here in the US. Her work in MMA earned her Trainer of the Year in 2022, and prior to that, she was with the United States Olympic and Paralympic Committee. All right, welcome, Dr. Linden.
Hi, everybody. How are you guys all doing? Good. Thanks for that very kind introduction. I have been tasked tonight to talk about the modality extracorporeal shockwave therapy. You might hear me refer to it as shockwave therapy. They go interchangeably, so if I'm talking about one, I am also talking about the other. So why am I talking about extracorporeal shockwave therapy? Because who knew it could shatter kidney stones, boost your performance in the bedroom, and make you a bionic man in one treatment session. Now, don't everybody get up and go run out of here and buy this modality, because I can tell you it's a little expensive, but it does do all of these things, which I think is what makes it so unique amongst recovery modalities. So let's learn a little bit about this modality. In 1980, the urology field picked up this modality and learned a ton about it. It was able to fragment kidney stones, which then allowed patients to pass kidney stones with no complications. There was about a 70 to 90% success rate when it came to passing kidney stones. So it became a huge modality used in urology. With that, they started looking into the orthopedics. They then discovered that it could break down calcifications, which then they looked into calcifications in tendons. What was it doing from a blood flow perspective? What was it doing in tissue regeneration and healing? So in the 90s, up until now, they've done a ton of studies looking at exactly the effectiveness of shockwave therapy. With that being said, in 2010, it became the #1 cure of inoperable erectile dysfunction, which is crazy, but you can imagine if it can do all of those things, it can definitely do a ton when it comes to orthopedics. So shockwave therapy has 4 main factors that I think are really important for you to take home tonight. First, its high energy acoustic sound waves penetrate the body's skin at various depths depending on which shockwave generator you're using. It's non-invasive, and like the name talks about extracorporeal, that means that the device is on the outside of the skin. This modality is used for wound care, scar reformation. We see that when it's placed, the sound waves penetrate and we see increased blood flow in those tissues. We also then see tissue regeneration. It reduces pain, and it also reduces inflammation, which is all things that we see day to day, especially in the physical therapy clinic. It's used by a shockwave generator that's placed on that skin. It's coupled with a gel solution that transmits those sound waves. With that, we've learned that we can use it in tendinitis, plantar fasciitis, shin splints, non-union fractures. We can pretty much use it for an array of different orthopedic injuries, and that's why it's become so popular. Yes, the downside is it can be quite expensive. We'll go in depth a little bit about the 2 types of shockwaves that you guys will see, kind of the cost, but definitely its new cutting edge technology is hitting orthopedic and sports, and you will see this throughout many sports facilities. So like I mentioned, there's 2 types of shockwave therapy. The first one is going to be your radial shockwave, and your second is your focus shockwave. Both equally produce those sound waves that penetrate the skin. As you can see from the picture, the radial shockwave looks like a little gun. What happens in that little gun is there's a bullet that goes back and forth quite rapidly, depending on the settings. That produces sound, which then penetrates the skin. From looking at that picture, you can see that the maximal energy flux and the density of those sound waves are going to be greatest closer to that superficial skin. And then it penetrates through those tissues. As it penetrates, those sound waves disperse. They're a little less intense as it goes through that tissue. So this radial head is mostly used for superficial injuries. We see it for ligaments, muscles we use it, or any kind of superficial bone injuries. We prefer the radial device. The focus shockwave, there's 3 types. There's electrohydraulic, electromagnetic, and the piezoelectric are the 3 different types of focal shockwave. With the focal shockwave, the biggest difference is you see that little blue end on that? That's going to be a water or gel, and that's where the sound wave penetrates through and then goes through the skin. So it's a little less intense on the patient. They tolerate it a little more, but I can tell you this, working in athletics, most of my athletes like that radial shockwave. They like no pain, no gain. We know that's not always true, but the immediate effect that they get on that radial head leads them to mostly ask for that one. We have both the radial and the focus at the UFC, and depending on what we're using site-wise, whether it's tissue quality, how big the athlete is, what body part we're using that on, depends on which shockwave device we will choose. The biggest thing I can say with these, just to remember, is the radial is going to get more bang for your buck at that superficial level, where that focal shockwave is going to get more bang for your buck deeper. So we might use that more for back, or if there's a larger individual or a lot of muscle mass that you might see. So what is the science behind the shockwave? I mean, I think I talked a little bit about how many various medical conditions it can do, but if I want to give you guys a 6-minute biology lecture, and you guys really are up for it, I can, which I doubt you guys want to listen to another biology class. We've sat through a lot of those. But just to give you a little bit of insight is it does stimulate growth hormone, stem cells in the body. We see an anti-analgesic effect. We see nociceptors. All of those crazy things that we learned in biology class is actually happening at the cellular level when it comes to this modality. We see ATP cycles. We see that there's tissue regeneration and growth, especially in an area that might not have that, especially those tendinitis, those areas where tendons just aren't looking healthy. This is a great way to adapt and put that on that area. Some of the most common injuries that we see from a musculoskeletal condition is, initially that was really popular for plantar fasciitis. We saw it a lot with our track athletes, probably close to 15 years ago. Most doctors would use it for Achilles tendonitis or plantar fasciitis, and it was a really quick, effective treatment. But at the time, we had to choose the parameters and pretty much crank it up as high as we could to get that effect, and patients just weren't tolerating it that much. So we've now, with additional research, realized we can put it at a level that's more comfortable for the patient, and then that patient can tolerate and still get those same benefits. The crazy thing about this modality is we can use it, 3 to 5 times a week if we want to. There's different protocols depending on size of patient, depending on which type you use. But I can tell you that it's a very well-tolerated, it's non-invasive, there's no downtime. I can literally do it on an athlete, and that athlete can immediately turn around and walk out and go to practice. Same with your patients, your outpatient clinics and things like that. I definitely think it's an underutilized modality, and that could be a cost factor. I mean, I would say your radial head one is going to range from anywhere from $12,000 to $25,000, where your focal one can range anywhere from $20,000 to $75,000. So it is an expensive modality, and that probably is the biggest limitation on why we don't see it in the general population. But I can tell you, if the general population starts to understand what it's doing for sports, how we can speed up that process of healing, how we can treat our athletes faster and get them back on the playing field, I think that will, in the future, carry that over so that people have more interest in shockwave therapy. One of the other cool things that you can see by this slide is they're now using it from wound care. They're using it on scars. So I've seen post-op patients that literally have a lot of scar tissue that's really having difficulty mobilizing, and we'll use this modality and it'll immediately break it up without having to put a lot of hands on. We also see that we can now use it for non-union bone fractures. That's a huge component, especially if we have stress fractures, things like that that are superficial with athletes, we can do that as well. It has a huge anti-inflammatory component from a chemistry standpoint, and with that, we're seeing that inflammation goes down in 24, 48 hours at a faster rate. I've had knee surgery athletes that literally acute ACLs that with 3 to 5 days, the swelling is completely out of it and their gait looks completely normal after a traumatic ACL, which is pretty impressive. So I want to leave you with just a few case studies. The first one I'm going to talk about is, I think a lot of people know who this gentleman is. Francis Ngannou is a world champ that used to be in the UFC. Pretty much one of the scariest men alive, people would say, but yet the most gentle giant that you could ever meet in your lifetime. But in his last defense of the title, 3 weeks out, he sustained a valgus force stress when he was grappling. And with that, he had a grade 3 MCL tear, as well as, we don't know either an acute or a chronic ACL, but we also know that there was an ACL tear as well. What's interesting in MMA is that ACL component, we see a lot of microtrauma over time, so we really don't know if it's one traumatic go or if it's multiple tears over time. That's what I would speculate, but that's a whole nother conversation and another topic to discuss. But with this, we immediately did stem cell injection into that knee, and then he did 3 weeks of aggressive rehab, receiving shockwave therapy 5 to 6 times a week. We would use anywhere from 4,000 to 6,000 pulses, and he would range between initially at a 1.5 intensity, and then by the end, as there's less inflammation, you'll tolerate a higher intensity, which will get more cellular proliferation, cellular regeneration, decreased inflammation, decreased pain, everything that we talked about. So that being said, we all kind of know the outcome of that. He did defend his title. He was able to fight in an octagon in championship rounds. He was able to win that title and keep it and defend it. And literally the biggest thing we did, of course we did physical therapy, BFR, all those other great things, and other modalities you will hear about tonight. But we definitely would say that shockwave contributed a lot to his success in getting back into that octagon. And my last case study would be on a basketball player that had chronic patellar tendonitis. He's a Clippers player, and recently I was chosen to see him this offseason. He had no changes in his patellar tendon over the past few years with eccentric loading only. This summer, I was able to incorporate shockwave therapy with him on top of eccentric loading, and we just did re-imaging, and his tendon quality looked significantly better, and all of his symptoms is reduced. So Just a little insight on how great this modality is. I hope I taught you something tonight, and I look forward to answering any questions when we're back out in the lobby. Thanks, guys.
Thank you, Dr. Linden. Our next speaker tonight is Mr. Saul Luna. Mr. Luna is an athletic trainer here at Texas A&M University with over 23 years of experience. He works mainly with track and field, though he's worked with athletes at the NCAA, world, and Olympic levels. Since 2018, he has been teaching courses in dry needling, and that's what he's going to be talking about here tonight. Welcome, Mr. Luna.
Howdy! Howdy to everybody that's here in person, and howdy to everybody who's joining us online. And so when we think about recovery, right, we think about being our best. We think about getting ready for that next competition, for that next practice, right? By the same token, let's not make it too narrow, right? Recovery also means getting up and going to work, right? We all got that mom or that your dad or your uncle who's got that pain that's, you know, they just can't get over, and it's really hindering their ability to live their high quality of life, right? So today, I want to talk to you about the amazing modality that is dry needling and how you can use dry needling to change the game, not only on the field, but also in your everyday life, right? So I want to start out with my little gratitude slide. So I want to thank the Huffines Institute and the Texas A&M Athletic Training Department for the opportunity to be here with you guys today. I want to thank Texas A&M Track and Field and Coach Pat Henry for being patient with me as I practice with them. And I also want to thank my mentors, Dr. Mark Scapitici, that's the fellow with the World Series trophy, and Dr. Vincent Henderson, who's in that group picture with the Texas A&M Aggie Track and Field team, right? And I also want to thank all the athletes who have allowed me to be a part of their story, because all we see are the gold medals and the smiles, but only they and I know the lows, the highs, and the needles that went into their performances. So let's dive in, right? So before we talk about what dry needling is, let's talk about what it isn't. Dry needling is not acupuncture. Acupuncture is a system of treatment that uses traditional Chinese medical principles to determine targets for needles, and the goal of that is to optimize the flow of qi or the flow of energy through the tissue. That is not what dry needling is. And I also don't know what's going on with that picture, but that's not dry needling, okay? The second thing is this. If I were to survey you guys and I were to bring up needles to you, somebody in here would say, I don't like needles. I'm scared of needles. Well, guess what? We've learned that there are only two fears we're born with, the fear of falling and the fear of loud noises. That means that every other fear that we have has been learned, okay? So that fear that you have of needles is probably tied to when you were a kid and you went to the doctor for your shot. I mean, I put a picture of that needle up there, man. That's a scary needle. It's got a scary edge. It's meant to do damage. That is not what dry needling is. You can't even see this thing. Look how flexible it is. It is a solid, sharp needle, almost painless when we insert it. Dry needling is not that shot that you're scared of. And the last thing that dry needling is not is some spooky system that's going to require you to give up what you do. There are people that say, I don't see where dry needling fits into what I do. Listen, dry needling is a tool that you use to help you take what you do to the highest level, right? You do you. You use your own system of assessment and treatment, and you can use this to enhance your outcomes. Now I'm going to channel my inner maverick here. It's not the plane, it's the pilot. It's not the needle, it's the hand that guides the needle, okay? So now that we know what dry needling isn't, let's talk about what it is, right? So dry needling uses all our Western principles of assessment, and we combine those with our knowledge of anatomy and physiology to select targets for needling. Most often, those targets are what are called trigger points. So those of us who are not familiar with what a trigger point is a hyper-irritable spot that is found within a tight band of tissue. So we call those knots, right? So when we press those spots, right, it will hurt. You might already be hurting, but if I press it, it may refer pain somewhere else, okay? It will limit my range of motion. My tissue might feel weak. Okay, that is what is called an active trigger point. I had a student athlete a few years ago that had an IT band problem, okay? We treated that IT band. We did the best we could to try to get her better with rehab, etc. But she just wasn't turning the corner. So I called my mentor and I said, hey, what do I do? We've tried everything. He said, have you ever checked the trigger point in the glute min? I said, no, but I'm going to try it, right? So what I did is I positioned her and I sunk my elbow into her trigger point. Why? Because I don't need a needle to treat a trigger point. I can use my elbow, I can use a gun, I can use a foam roller. But this right here gives us the fastest effect, right? So after about a minute of sitting on that trigger point, guess what? Knee started aching. 2 treatments later, pain-free. Why? Because her problem was related to a trigger point, right? That is what's called an active trigger point. A latent trigger point has all the same characteristics, so limits range of motion, makes the muscle feel weak, right? But it's only tender if you press on it. Okay, so when I try to explain to people what that means, so who in here has played Call of Duty, right? Someone in here has played Call of Duty. If you've played Call of Duty, you've had the unfortunate experience of stepping on a landmine, right? Those things are meant to harm you if you step on them. So why would you step on it? Because you didn't know it was there, right? Same concept with the latent trigger point. It is in your muscle, right? So you strain the muscle, you overstretched it, your body didn't like it, locked it down. Now you're tight. You don't even know it's tight, right? So you continue doing your thing. Unbeknownst to yourself, now the research shows 2 things, right? When you have a latent trigger point, that will alter the concept of reciprocal inhibition within your tissue. So in order for me to straighten my elbow, this has to lengthen, this has to get tight. If there is a trigger point within this muscle, it's not going to relax completely for that tricep to do its job. So guess what? The tricep has to work harder to get the job done. So what does that mean? More strain on those tissues, right? So now this muscle is straining hard to do its job. It develops its own trigger points. If I continue to strain it, there will be a tearing, an injury, right? And now I got a bigger problem, okay? The research also shows that these latent trigger points can interfere with the timing of muscle firing to complete joint movement. So in my shoulder, there are muscles that are designed to pull my humerus down so it can slide under my acromion, right? If the muscle that fires to bring my humerus down doesn't fire with the right timing, I'm going to end up with an impingement and long-term, possibly a torn rotator cuff, right? So all bad. And so when we're trying to optimize our athletes and we're trying to help them come back and be ready to perform, etc., right? Our target is going to be this latent trigger point. Why? Well, an active trigger point hurts. So you already know that they're in pain, right? So what we're looking for is those silent muscles, right? Because I know that if I treat those muscles, the muscle's going to fire, the timing is going to be better, and I'm going to have a stronger muscle. I'm going to have a better performance, right? So how can this needle affect that tissue? How can this one needle do all that? Remember what I said, it's not the plane, it's the pilot, right? So I'm going to teach you now how the tissue responds when I insert a needle into the body, right? So think about a plant, right? So we all have that plant that we neglect. If we neglect it, it starts to wilt, right? We neglect it further with water, depriving it of water, it starts to shrivel, and then if we're not cautious, it dies, right? But if we water it at just the right time, it bounces back with no issue, correct? Okay. Same thing happens in your body. Remember I said that a trigger point is a hyper-irritable spot within a tight band. That tension in the tissue is going to limit the blood flow in and through the area, right? So when there is limited blood flow through the area, the tissue begins to undergo changes, okay? And so the muscle will get tighter and tighter and tighter. Think about that plant shriveling, right? By the same token, the lack of oxygen in the area wakes up these specialized nerves called nociceptors. So now you got a pain signal going into your brain, right? So when I insert a needle into the tissue, well, duh, it's going to bleed, right? So when I put a needle into the tissue, the body responds by releasing substances that open up the blood flow, vasodilate the capillaries, right, to bring blood flow into the area to nourish it, thus restoring the tissue back to its function, right? By the same token, that area is now oxygenated, so these nociceptors turn off, right? All from inserting a needle into the tissue. You guys can see, so I shot an ultrasound, right? And so the picture on top is pre, the picture on the bottom is post. I stuck a needle in, right? Now you guys may not be able to see this too well because like I thought it was a weather system coming out of Chicago, right? But now I'm like, okay, wait. So can we agree the tissue on top, right? You see how it looks kind of compressed, kind of tight, right? I put a needle in, and now the tissue in the bottom, see how it's got a little bit more space, right? So once again, when I put a needle in the tissue, there's communication with the spinal cord that sends back a message to the tissue to relax, right? So once again, I can have a relaxing in the tissue. I've got increased blood flow that helps to nourish the area. I've got oxygen to help to turn off the nociceptors. Now I have better function, right? So how does this all look like when we get into the whole performance thing, right? When we get into the whole performance thing, you come in, you see me, I'm trying to get you ready to go. You're not in pain. So I'm looking for these trigger points. I hit these trigger points, I deactivate them. Now your muscle is ready to fire, and now you're ready to go out there and perform and do your best, right? So enough from me. I thought it'd be cool if we could hear from one of my athletes.
What's up, everybody? This is Lyndon Victor, two-time Olympian, two-time NCAA champion, two-time Commonwealth Games champion, and recent World Championship bronze medalist. I am just thrilled to share with you guys some of the benefits for me using dry needling. I was first introduced to dry needling my first year at Texas A&M, and since then it has always been a big part of my regimen. I use dry needling for one, first of all, my recovery. It's a big part of my recovery. I use dry needling probably 3 to 4 times a week, depending on how strenuous training is. I also use it as a form if I have any injuries or anything to get the muscles loose. So my encouragement to you is, whether you're a professional athlete or a collegiate athlete, try to find a way to incorporate dry needling into your regimen, because it would not only make you feel better, but it will help you have a longer career.
So why are you going to stick needles in my body? Because when I stick a needle into your body responds by releasing substances that increase blood flow. That increased blood flow will nourish the tissue and help to oxygenate it, to turn off the nociceptors. You feel better, you function better, and your performance is optimized. Looking forward to listening to your questions when we come back out. Thank you.
Thank you, Mr. Luna. Our next speaker tonight is Dr. Joyce Tyrrell. Dr. Tyrrell is an athletic trainer and professor at Morehouse College. She also owns her own private practice. She specializes in physical medicine and rehabilitation, and her research is in nutrition in women and children. Tonight, she's going to be talking about cryotherapy, a method that she uses quite a bit with her patients. So welcome, Dr. Tyrrell.
Good evening. I'm honored to be participating in Hilliard Discussion 13. The topic of the hour, the ultimate modality for performance, specifically cryotherapy, is relevant and specific for both the athlete and the non-athlete. During the next few minutes, I will engage you with conversation about the physical effects of cryo, the benefits of cryo, and then the application of cryo. I encourage you to question, challenge, and engage with the content. Please note, this is a talk for general information purposes only. Before you make any decisions or take actions, please consult your healthcare provider. Thank you. So, historical perspective. For many centuries, cryotherapy has been used for its health, therapeutic, and sporting recovery benefits. The prefix cryo means cold or ice. It doesn't mean to cry. I've had athletes, when I apply it, they look as if they really want to cry because it's really cold the first couple of minutes. But the prefix means cold or frost, and cryotherapy is the application of extreme cold to treat, let's say, the mundane bruise or a sprain, skin ablation. Egyptians and later Hippocrates appreciated the analgesic and the anti-inflammatory effects of cryotherapy. And based upon science, we have gained a better understanding, knowledge of cryotherapy, and we've refined the techniques. So let's just talk about the physiological effects of cryotherapy. So we're going to go back to school, go back into the classroom, and we're going to think about the physiological effects of cryo. So think about the time when you've had an injury. What do? You may have been advised to apply ice post-surgically. You may have had soreness from an exercise bout, or you might have just had a back pain. What happens when that ice is on the skin? So let's just take a look. Vasoconstriction. Vasoconstriction means to narrow, to make small. So the vessels are actually decreased in their diameter, so we get less swelling, less bleeding in the area. And that's what we want. So in frame A, we see the constricted blood vessel versus its counterpart. And then in frames B and C, we see blood that has come onto the site as well as we've got swelling. So it is thought you get better outcomes when you vasoconstrict those arteries. So that's why cryo is important. The next frame, we have 3 graphs here. We're looking at nerve conduction velocity. So what does that mean? The nerve will slow down its message to the brain that I have pain. So in the first slide here, the second slide, I'm sorry, reflects nerve conduction. What happens is icing, we see that those levels are the same. They're about 35. The experimentals are in the dark. The controls are in the lighter color. So as we apply that ice and that skin starts to cool at 15 centimeters, we see that the nerve conduction velocity has slowed. So the message is not getting to the brain that, oh, I'm in a lot of pain. We also find that the pain threshold has increased. So the bar has been raised. So by the bar being raised, it is thought now I can tolerate a little bit of this. So those are the things that we want to look at when we look at the nerve. We want to understand that the message is slowed. We understand that the bar has been set, the pain threshold has been raised, and therefore we can tolerate the sensory. Then we have this endorphin release. So this is what gives us the analgesic effect. So when the ice is applied, within 2 minutes you start to numb out. And it's because we have an increase in endorphins. And so the endorphins act to give us that analgesic effect. And then finally, we have muscle relaxation. We want the muscle to relax. Just think if you had an injury and the muscle was contracted, you're going to have greater discomfort. So in the muscle, there's a mechanism called the muscle spindle. And what happens is when the ice is applied, the muscle spindle is inhibited. So it doesn't react to the stretch. So as a result of that, you get relaxation of the muscle. So if that's the case, those are the physiological effects. Let's look at what the research says about cryotherapy. So cryotherapy, the ultimate recovery modality for performance. So the 2 words I want you to look at here are ultimate and recovery. Ultimate means the final. There's nothing else, okay? And then recovery means to reset back to original. So let's see what the research says about the ultimate recovery modality, cryotherapy. So this is what the literature says. Following exercise, cryotherapy is indicated when rapid recovery is required between exercise bouts. One of the other articles that I read says a sample of Irish emergency physicians highlighted the fact that 73% of consultants frequently prescribed cold, 7% never suggested to use cryotherapy, and 30% is unsure about the benefits of using cold. Another article read indicated that cryotherapy is utilized to improve muscle recovery and pain, as well as to improve the anti-inflammatory response in the body after exercise. And finally, many modalities of cryotherapy application have been recommended for the recovery of physiological systems after exercise-induced muscle damage, including whole-body cryotherapy. So that's what the literature says. So when we look at the application of this modality, what are we really thinking about? So we've got the ice pack, we've got whole-body cryotherapy, and we've got cold water immersion. So let's look at the whole-body cryotherapy. This has gained momentum in the last, 10 years. So the historian here, Dr. Yamaguchi, started working with his patients who had rheumatoid arthritis. And he was actually using liquid nitrogen. And so with the cryo chamber, it's a chamber you walk into, Your head is maybe covered or not, but definitely your digits are covered. All right, the duration is only 2 to 3 minutes, okay? The medium here is liquid nitrogen. It is freezing cold, okay? The chamber, again, can go down to as low as a negative 200, 250 degrees. I was visiting UGA's sports medicine facility this summer, and they have a cryo chamber there. And I was talking to the head trainer, and that's when he said, oh yeah, we get the temperatures down to as low as negative 250 degrees. Don't have any information on the skin surface, but again, the muscle temperature should be at about 10 to 15 degrees. Otherwise, you're not getting the physiological effects that we talked about earlier. And the price point. So in Atlanta, that's where I'm from, to get 2 sessions of cryo is about $75. So it's not cost prohibitive. And then again, Dr. Yamaguchi was the actual historian. Then let's look at ice packs. Many of us have used an ice pack before. So we want to apply the ice 15 to 20 minutes. The medium is water in its solid state. Again, we want that temperature to be about 10 to 15 degrees. And as far as the price point, pennies to the dollar, okay? And this particular modality or application of cryo was actually first kind of seen and used when Napoleon's surgeon, Baron Dominique Larrey, actually packed his patients in cold, frost, snow, ice, so that would allow him to do his surgery without having really too many complications. So that's just the historical perspective of the ice pack. And then finally, we have cold water immersion. So literally, you're in an ice bath with water, and the duration should be about 10 to 20 minutes. Again, the medium is water. The water should cool to about 10 to 15 degrees. And again, I don't have any information on skin, but I can tell you a little bit about the historical perspective of this. Edwin Smith Papyrus, we saw this back in 3000 BC when he wanted to drop the temperature of his patients. If they had fever, they immersed them in cold water. So in essence, these are some of the historical perspectives for the practical application of cryotherapy. The physiological effects, just to recap, we want to vasoconstrict, make the artery smaller so we get less swelling, less exudate, less swelling and bleeding in the area. We want to make sure that we slow the nerves so that the brain doesn't get bombarded with so much sensory information. We're going to raise that pain threshold. We're going to then, therefore, be able to tolerate more ice. I mean, more of the sensory that we're getting. The muscle contracting, muscle is actually relaxed instead of contracted so that the muscle spindle is inhibited and it doesn't work. And then finally, for the analgesic effect, we're going to actually get that endorphin that's going to be released, and it's going to give you that analgesic effect. So again, thank you for having me. I've had a wonderful time here, and enjoy the rest of your evening. Thank you.
Dr. David Reagan-Suarez. He's at Rice University and Houston Methodist Hospital. And at Rice University, he is the team physical therapist for all sports. Prior to being at Rice, he was at Memorial Hermann, Rockets Sports Performance Institute. I can get that out. And he also participated in helping with the athletic care at Sam Houston University, as well as here at Texas A&M University. He's talking on a topic tonight that's of particular interest to myself, and hopefully it is to you as well. It's on cupping. So welcome, Dr. Suarez.
Howdy. This is my first time I've gotten to say that other than in an email, so I'm really excited for that. So thanks, Dr. Yentes, for allowing us to be here, and I want to thank Texas A&M for having me back to be able to share some of the things that I've learned from over the last year when I did my D1 fellowship here. So I want you to take a second and think about cupping, and when was the first time that you saw it? It was one of the first times I had seen it was the 2016 Rio Olympic Games, when athletes such as Michael Phelps walked out onto the biggest stage with these weird circular marks on their body. People began thinking, how does this help with performance, and how does this help with recovery, and how does it get us and our athletes to the biggest stage? But this technique has been utilized over the last 5,000 years, and this is an ancient Eastern medicine technique. Back in the day, it was used with animal horns or ceramic cups, and then today, it has progressed over time. In the photo, you can see that this cup is a circular rim with a rolled rim, which is important architecture that these ancient civilizations founded 5,000 years ago. It's placed on the skin with the suction that draws the skin up and the different layers of the skin up into the cup, which gives it a stretching effect. Later on in the presentation, we're going to talk about why this is important and how it's transversed over the last couple of years. So cupping techniques. As I said earlier, it's progressed from a ceramic cup, an animal horn, and even bamboo to what it is today in plastic and silicone cups. What's cool about these plastic and silicone cups is that you can have the athletes do it to themselves with just a manual pump, a handle pump, or the silicone cups that actually raise the skin on their own after they place and they can gauge the different pressures. So practitioners can do this as well as the athletes themselves, and they can go to a feel of what they deem is necessary. There's 4 different types of cupping techniques. The first is going to be dry cupping. Dry cupping is when an athlete just lies statically and a cup is placed and sits for 5 to 15 minutes. And in this technique, you're going to employ more cups, so around 6 to 10 cups of different sizes to cover an area. Flash cupping is done within bouts of 30 seconds, and you're going to use 1 to 4 cups. So the cup is placed, the suction is provided, and then it's released to just give the layers under the skin a different type of stimulus for relaxation or pain regulation. The third one is wet cupping. This is the oldest type of technique, and this is done by a static cup placed in an area. The cup's then removed so the blood flow is stagnant to that area. Then an incision or a scrape is made in that area, and then the cup is placed back on that area and blood is drawn out. This is what these ancient techniques were, where it thought that there was removal of harmful substances and toxins from the body through the blood. And then the last one is massage cupping. Massage cupping can be done one of 2 ways. The athlete can lie there statically, such as the cup on their back, and it can be moved up and down, and that circular rim gives it a multi-angle approach of pulling those tissues in different ways. So the massage cupping covers a bigger surface area of moving different objects and manipulating them from distal segments. Or the athlete can be lying there statically and then moving, giving some active motion, and it can be stretching the tissue in and of itself. The dry cupping and the massage cupping are going to be 2 of the more famous types of techniques that we're going to see in the Western world here today. In the photo on the bottom, you can see someone that's had cupping done on their back. Typically, we've all seen the photos of there's what feels like 50 cups or 30 cups. The amount of cups you use, the number of cups you use, also dictates the negative pressure environment. So the more cups used, the more negative pressure environment, which enhances the blood flow to the area, as well as the intensity of the suction. So some suctions can be between 45 and 60 millimeters, and some of our cupping sets will tell us. But as we add more cups, the more intensity of the cups is used. So mechanisms of cupping. How does cupping work? We actually don't know. We do it, but we aren't sure. There's many different theories out there of how cupping works. 3 of the popular reasons are going to be pain reduction. So to summarize that, pain reduces pain. It gives us a small inflammatory response through that negative suction or negative pressure environment with the suction, and it inhibits pain on its own. The increased blood circulation is going to be an amount of blood flow to the area that helps calm down our system. That more blood flow to the area removes some of these negative markers that we have in soreness and in pain. We have an immunomodulation theory, which just tells our immune system that, hey, something's happening to our body through that suction, which causes a little pain, and we need it to calm down. And then lastly, as I had talked about, the ancient Chinese medicine, where it was the blood detoxification. It was actually removing substances and harmful toxins through skin to help give us our recovery effect. But as rehab providers, we like to utilize this fancy term called mechanotransduction. Typically, we like to give mechanotransduction through exercise, so pushing, pulling, compression in different ways, but this can be done through modalities too. Modalities such as cupping, dry needling, shockwave, where the skin, it likes human touch, it has a neural connection through human touch to the brain, but it helps modify those cells on a different level to give us that recovery. So benefits to cupping. We talked about why cupping works. There's some physiological benefits. So it helps improve motion. We can do that through active motion with the cup on us. We can do it through moving. And it helps those deeper layers of tissues be a little bit more flexible and pliable. We can do it through microcirculation, so we just enhance blood flow to a certain area on the body, which gives us that effect of feeling recovery. It removes those harmful markers within inside of us. And then it has regulation on the nervous system. So our nervous system is what regulates our anxiety, our pain, when we feel like we're not ready to perform. So it'll have some systems on that with it. It just improves that down regulation of that nervous system. But psychological benefits are probably the why cupping is most effective. Typically when an athlete comes in and they say, hey, I like cupping, it helps me feel improved, that's the technique I'm probably going to use. That's the technique that they have the most affinity for, and so that's what we want to induce with cupping, is those psychological benefits. A lot of people will say that it helps with neuromuscular fatigue, it helps with pain, and it also helps with recovery. This is what helps us feel like we're ready to compete the next day. We're pain-free, we're ready to go, and now we're ready to perform. So, cupping applications. When and clinically, why will we use cupping? You can use cupping in different ways, and I'm going to talk about how it's with the moving and the static cupping. We might want to use cupping before a treatment session, before a game, before we're ready to perform. We can do this through the dynamic cupping or the moving cupping. You can see in the top photo where an athlete's moving their leg up and down with the cups on. And this is going to help with that range of motion. So they have improved range of motion, they have improved extensibility, they're ready to perform in that area. Or we might use it after a session. So after a session, the cup is just sitting there, the athletes are going to sit there, hang out, look at their phone, look at film, think about the game, and it just brings them to a better state and ready to do more things the next day. This is the hierarchical pyramid of recovery. And you can see that cupping is going to be in multiple different spots in this pyramid. You might put it one way or the other, but what I want to express is cupping is not supposed to be used in isolation. We can't just allow cupping to be done for improving flexibility, improving pain, or ready to perform. We have to use it in adjunct. We're going to talk about dry needling, shock wave, ice. All of these are modalities that we're all going to use in adjunct in one another, and then find what the athlete has the most affinity for to be ready. I think Major Carson's going to go over that in more detail and talk about how all these things can be incorporated in one another for the ultimate performance. Thank you.
Thank you, Dr. Suarez. Our last speaker this evening is going to speak to us about how he takes all of these techniques and modalities and others and cares for our nation's tactical athletes in the Air Force. Major Evan Carson, class of '09. Whoop! There's a few of them. He is currently the Operations Medical Readiness Commander for the 23rd Special Tactics Squadron for the Air Force Special Operations Command. Welcome, Major Carson.
Hi. Thank you. Good evening. Man, back in 2007, 2008, I was sitting right where you were. You guys are probably like learning your ABCs back then or something. You guys still awake? We're gonna have a little fun. Hey, I just want to thank Dr. Yentes and her team. The hospitality has been first class. It's great to be back in Aggie land. Stay with us. There's light at the end of the tunnel. We're almost done tonight. And even more so, hang in there through the rest of your undergrad. It gets better, I promise, okay? So, like she said, I'm an active duty physical therapist in the United States Air Force. And when people hear the word or the phrase Air Force, they think of fighter jets, they think of cargo planes taking strikers across the Atlantic to Afghanistan, and it certainly is those things. However, I work in a very small niche within the Air Force called Air Force Special Operations Command, and an even smaller community called Special Tactics within Air Force Special Operations Command. So I want to talk a little bit about what Special Tactics is before we get into the meat of the presentation. So these are my guys. Special Tactics is essentially the integration of the ground battle with the assets we have overhead in the air. So our soldiers are qualified in all the basic soft skills, such as shooting, moving, and communicating. They're all military freefall qualified, so they're the guys that kind of pickle out the back of the aircraft and do the backflips and then guide themselves into the landing zone. They're also dive qualified, so they have some underwater insertion capability. And then they have qualifications in what we call AIEs, or aerial infiltration and exfiltration capabilities. So what you see there in that picture is those guys climbing a caving ladder. They're usually doing that out of a helicopter, so they can go and assault on a target. And they lift a ton of weights. So as you can imagine, all these activities kind of result in a body that breaks down. But what makes these guys unique is not just the basic soft skills they have, but what they bring to the fight. So combat controllers can basically land an aircraft in the middle of the desert out of a backpack and a radio. So they do the job of an air traffic control tower out of a backpack. That's pretty sweet, right? Pararescue jumpers are specialized in rescuing downed pilots, the combat search and rescue, extrication, battlefield medicine, casualty evacuation. And then we have special reconnaissance airmen that fly drones and do a lot of surveillance and reconnaissance behind enemy lines. So pretty neat capability that we bring to the fight that maybe our Navy and Army brethren don't have. And so the Air Force is heavily invested in keeping these guys around because we paid about $2 million to bring them up through the pipeline to make them operational. And SOCOM has a $100 million program per year to take teams like mine and put them in tactical or squadron-sized elements of about 100 or 200 people. And so that's what we're going to talk about. We're going to talk about recovery and how we do that in my unit. But first, one caveat. These are my views, not the Air Force's. They want me to say that. So everything here is my opinion, not necessarily policy of the Air Force, okay? So with that, we employ a situational model for recovery because we might recover anywhere. We might be able to recover in the gym or in our sport medicine clinic. We have nice things. That's the ideal situation, but we might have to recover in a container, like that guy riding the bike. We might be on a plane recovering, or in a broom closet, as you can see right there. That's legitimately treatment in a broom closet. So we have to apply a situational model. All kidding aside, we have to consider what the evidence is. What does the research say about a certain modality? We can't just fall for any fad that comes along, right? And things that we do want to buy, we have to consider, what does it cost? How much space does it take up? How much time does it take to implement and utilize? We have to think about location. Sometimes I'm treating guys in my clinic, but other times I'm on a teleconference with a guy who's in the Middle East or in South America, and I'm having to guide him through some recovery for a back injury that he's had jumping out of an airplane. And then finally, Dr. Suarez hit on it a little bit, but what's the operator's preference? The placebo effect is very powerful, and we need to harness that. So for us, recovery is a blend of the individual, the task, the environment, and our available tools. And over the next 3 slides, I've kind of organized it in 3 domains just for simplicity's sake. Soft tissue, joint, and I kind of lumped energy and mechanical modalities all into one. So first up is soft tissue strategies. I love dry needling. It is a powerful, immediate effect. It's super portable. All I need is a box of needles and a sharps container and some sanitation equipment to do this wherever. You saw the broom closet picture. But I can intervene in a lot of different tissue types with dry needling. You can see right there, I'm needling that guy's tendon to bring about blood flow, alleviate some soreness that he's had chronic patellar tendonitis. Bottom right-hand picture, I basically built a picket fence around his ankle sprain in an effort to bring blood flow to the area, stimulate the lymphatic system, and kind of flush that swelling and inflammation out of there. I can needle muscles to reduce muscle soreness, kind of like Dr. Luna talked about. I can intervene in the nervous system, just calm down pain response. So I love dry needling. It makes my job a ton easier. If for whatever reason the operator, doesn't want to be dry needled, which is pretty rare, you can tell by the tattoos, these guys kind of like needles. Cupping is kind of a decent option, a number 2 backup plan. So you can see in the middle 2 pictures there, I do some cupping of the paraspinals, and for the guys that really want that done, it's a powerful effect. But I really like rolling and tempering. So in the top right picture, you see that guy right there. He's got 80-pound cylinder on his quads, and he's rolling it back and forth. That's called body tempering. And you can do that with a heavy object lying on you, or you can lie on a foam roller. So one thing we do when guys aren't around is we build them a mobility kit. And in that mobility kit, they can take it with them downrange. They can take it when they're training in the field. It's got a foam roller in there. It's got a supernova ball. It's got a lacrosse ball and a whole bunch of bands so that they can take things that we've taught them in the clinic and employ them on their own. So I don't have to be there. So obviously those are very cost effective. And then the bottom left-hand picture, we do some stretching. Stretching has to be in every recovery routine, but it's like we don't have to spend much time on it. We don't ever stretch more than 60 seconds because we don't want any effect on performance. If we're stretching before a field exercise or before a fitness routine or something like that. But once a week during our recovery time on Wednesdays, we focus on the hip complex primarily with stretching. That can be a big problem in our patient population. So next we have joint strategies. Maintenance of joint mobility, especially of the spine, is of great concern to me and my population. Our guys, they carry really heavy loads. Those loads are often like uneven, and they're carrying them over uneven terrain, in the dark, climbing up mountains, and that just wreaks havoc on their spine. So I do a lot of joint manipulations to try and maintain that joint mobility for rehab and for recovery both. But if I'm not there, right, that's resource costly to have the physical therapist there with them. We go back to the mobility kit. And so in the middle pictures there, you can see on the bottom, that guy is he's using that band to kind of pull his hip joint forward while stretching his hip flexor, working on anterior hip mobility. And then that's actually one of the spouses. We put on a spouses event to kind of show them what we put their husbands through all the time. We need that buy-in. And she's working on thoracic mobility. That, more than anything else, is probably the most limited thing that we see because guys have a helmet, they have night vision on top of that, they have armor that weighs like 25 pounds, they have radios, batteries, they have ammunition, a rifle, and a ruck if they're a PJ. And that ruck probably weighs 65 pounds, so before you know it, you've got like 150 pounds of stuff. So the thoracic spine just gets super locked up. So we dedicate a lot of effort towards thoracic spine mobilization. And that's the bottom picture, or the bottom right picture as well. That's not me. That's a buddy of mine. I wouldn't be caught dead in that position with a patient. They wouldn't let me live that down for a second. But he calls that his signature move. So what he's doing there is he's taking his fist and he's pushing down into that patient's thoracic spine, that patient's breathing, trying to open up his mid-back. And I was pretty critical of this, making fun of that guy, but I'll be darned if that guy didn't come in the next day and was like, "Doc, I feel amazing." So I'm missing something. My friend's got some secret magic I don't know about. Okay, and then finally, energy and mechanical modalities. So this is the stuff that's expensive, takes up a lot of space, it costs a lot of time investment for the guys. We have nice things, so we utilize them. Right now, contrast baths and sauna are kind of the hotness, if you will, pun intended. Sorry, dad joke, my kids are back there. They didn't laugh either, don't worry. And then, so what they do is we took a protocol out of Dr. Soberg, who's out of Denmark, and she's done a lot of good research lately on contrast. And what she's finding is that if we do a cold plunge up to our necks for 1 to 2 minutes in 40-degree water, and then get out and get in a sauna that's about 170 degrees for 10 minutes, and then repeat that, beginning and ending with cold, we can get some really cool benefits with metabolism, with immunity, decreased anxiety, improved sleep. So that research is kind of in its infancy, but I'm excited to see where that's going. And then bottom right-hand corner, that guy is doing active recovery, which I'm a big fan of, especially on a bike with slow impact. He's got blood flow restriction on both thighs. So we squeeze those thighs, about 50 to 70% for recovery, and we do a low impact activity, submaximal work. We get a really cool effect in cardiovascular improvement, as well as some growth hormone secretion, maybe testosterone, IGF-1. Some pretty exciting stuff coming out of the BFR world. So we do utilize that when in garrison, or when they're on site with us. And then finally, the middle picture right there, That's actually in Africa. They carved out a little corner of their hooch to dedicate to recovery, so we're winning. They took the Normatec compression garments with them. They're not super popular, but we have them. They do relieve muscle soreness, and the guys, they utilize them a little bit. But mainly it's the therapy dog that does all the work. He's not Reveille, but he's pretty awesome. That's my dog Timber. Cool, so I'm about out of time. I know that was super fast. We talked about what special tactics is, why the guys need help, and kind of how we do it. So looking forward to more questions. Thanks.
Thank you, Major Carson. As you notice, all the speakers are going to join me on stage here, and it's now time for our Q&A panel. This is time for you to engage with them and ask your burning questions. So there's 2 microphones in the aisles, and please come on up. You can queue in front of a microphone, and then we'll call on individuals. Do not be shy. Come on. Nobody. I've got a few stock questions. Thank you. Is that Rob? Thank you, Rob. I appreciate you. All right, Rob, go for it.
I wanted to thank all of you guys for your talks. They were very insightful. I have a question specifically for Dr. Terrell. You mentioned using cryotherapy to almost reduce the pain of the patient, yes. And with the kind of new age of getting rid of rest, ice, compression, elevation, are you using these cold modalities as a way to almost prime them for graded exercise, or just a single stimulus exposure?
Well, it can be both, but I work in the clinic, and so many of the patients, after we do treatment on them to keep that swelling abated, because we have them doing all kinds of exercises, we want to make sure we just apply that ice to keep the swelling down. But I've seen it used in various ways, but I'm more in the clinical setting now, and so that's what I see and how I use it on my patients. So I don't know if that answers your question, but in the clinical setting, this is what I'm doing.
Awesome.
And how I'm applying
Thank you.
it. Yeah, thank you for your question.
Anybody want to add? Anybody else want to add anything about how they use ice
Yeah,
therapies?
like for me personally, right? So like you said, it reduces the pain. So once I get them into that subacute phase, so we know that the collective tissue is just trying to regenerate response to forces, right? So in order for us sometimes to put, appropriate forces through the tissue to guide the scar tissue laying down, we need to numb them up a little bit, right? So sometimes I'll use a little bout of cold just to numb them up, and then I am able to have them execute the exercise with more comfort, right? And then we can get more done. And then also you get the benefit of the muscle pump, right? Because the tissue is helping to pump, the swelling out of there, yada, yada.
Excellent. Please go ahead.
Hi, so I believe it's Dr. Suarez. I'm a huge fan of cupping as well, but I was wondering what you could say or what you knew about, I assume it's a part of massage cupping, but fire cupping?
Fire cupping?
Yeah.
Yeah, so that's, there's some danger with that. If you ever look up cupping on Google Images, people put the alcohol swabs in there and then they light it, and has an effect to burn people. Obviously we aren't doing a lot of that in the Western world as of right now. We're gonna, out of a practicality standpoint, in the athletic training room with some of these collegiate athletes, we need something that's quick and more practical for them to either do on their own or we can do quickly on ourselves. So you're going to see that more in a more specialized type of cupping situation, but in the athletic training room, we're not going to be utilizing that much. So I've never personally done that, and I don't know if I will anytime soon. So.
Got it. And then just one really quick for Mr. Luna. Where is somewhere in Bryan College Station that I can get dry needling if I was interested in trying it?
I'm sorry, ma'am.
I couldn't hear
I'm
you
sorry.
either. You pulled it down. Just pull it down. So yeah, there
Is
you
there
go.
a place in Bryan College Station where I could try dry needling if I'm interested?
So I don't know if I can
Yeah, you
name
can.
actual businesses.
Yeah, you can if you want to.
Can I send an NIL deal for that, right?
Yeah.
So, I know. Well, so for example, I'm personal friends where I know the individual who owns Alpha Sports, right? So I know they offer it there, right? And like I said, I know there's other. So everybody else in College Station, I don't know about you, right? I just know about
That's
Alpha
fair.
Sports because I know that guy. I know him, and I know he offers it there. So Alpha Sports Cairo, they do it.
Awesome. Thank you.
Go ahead.
Hello. First, wanted to thank you all again for coming in and all your knowledge, and thank you for your service, of course.
My pleasure.
I have a question for cryotherapy. So I was a swimmer growing up, and number one complaints of all of us were like, oh my gosh, the water's so cold. We hate this. It made practice miserable in the first like 10 minutes, but was there actually like a benefit that the water was actually cold for the long-term effect of our practice then?
So that question is directed to me?
Yes, ma'am,
Kyle.
sorry.
Yeah, so you were asking what the long-term
Swimming.
effect?
So in swimming, the water, right?
Oh,
the
okay.
swimming's
I
The
didn't hear
pool's
that.
always
The
freezing, no
pool is
matter what pool
freezing.
you went to.
when you're
Okay.
a swimmer.
Yes.
Is there help there? Is that cryotherapy?
Well, depending on what the temperature is, it could very well be. So that's like the immersion application. And if the temperature gets down to even 10 degrees, you're going to start to get those physiological effects that we actually see. So how does that affect your ability to do the sport? Is that your question, or you're just asking?
I was asking if they had an overall benefit, because we always thought it was just because our coaches didn't want to pay to make the water hotter. But maybe it was actually healthier for us to
Yeah,
have
I think
the water
if
cold.
anything, if there was an injury you may have had, it'll help keep the swelling down because you're using the tissues. Okay, the only thing I would say to you, I don't think it's cold enough, the temperature in the water, to get to maybe freezing that muscle spindle. So in essence, you want the muscles contracting, you don't want the muscles relaxed. So I don't think the temperature is at a point where it's too cold or cold to the point where you're getting some of the physiological effects that were, brought out in the talk. So other than that, I can't say anything. I don't know if my peers have any other thoughts about it.
Yeah, I have one thought on that. I highly recommend the Huberman podcast. If you guys have ever listened to him, he had Dr. Soberg on that I referenced in my presentation. And she did a great job of kind of spelling out all the findings they had from the recent research that was published in May. And one thing they talked about was the water, to get a therapeutic effect that they're looking for, the metabolism changes, the water temperature had to be, they gave it in Celsius, so public math is hard, but I think it was 45 degrees was kind of that cut line. So if you got into a cold immersion under 45 degrees for at least 1 to 2 minutes, that's when you could start seeing some of those metabolic changes that they were referencing. And they did have a maximum per week too for that. I'd have to go back and look, but I want to say it was somewhere around 20 minutes. So there is kind of a sweet spot you have to hit, and probably your pool wasn't cold enough to actually elicit the changes we're talking about. You kind of have to feel that cold shock. If you guys have ever jumped into a really cold pool or done like a polar plunge or something, it's that initial, whoa, my body just freaked out. So discomfort because of cold is a little bit different than therapeutic cold, right?
Awesome, thank you. And a quick question about cupping. What is the process that you guys will teach your athletes in order for them to be allowed to cup themselves?
Yeah, so typically let them trial it out quite a few times. Probably actually have them just purchase some on their own at home, especially in like a clinical setting with just general population. You can have them do that. Probably the silicone cups are going to be the best because they don't have too much suction, because you don't want someone to have too much suction to injure the tissue underneath. So like the manual cups aren't going to probably be the best bet, but the silicone cups are probably going to be more. So they vary in price ranges and sizes and stuff. So college athletes just might be a little bit, they have the accessibility to come versus like a general population. They might have that opportunity to do it at home.
Awesome, thank you. Thank you so much.
Thank you.
Thank you.
Thank you.
Again, thank you so much to all of the speakers, but I had a question directed towards Mr. Luna. What would be your recommended kind of process of like being like introduced and like being like qualified or like certified to do dry needling? Like what does that look like, and what is kind of like the price point of acquiring like that kind of certification?
So that all comes down to whatever medical profession you go into, right? It's because different medical professions have different standards and requirements, right? So for me, I'm an athletic trainer. So in the state of Texas, according to our Practice Act, I can do anything that my physician, because I'm working under their authority. So anything they delegate their authority to me to do, I can do, right? So it just depends on so if you're going to go into PT, or if you're going to be a physician, or you're going to be a chiropractor, you're going to be an athletic trainer, right? So each one of those has their own guidelines for what it takes. But like I told you in my talk, right? So dry needling, like, dude, we're making such a big deal over the tool. It's just a tool, right? it's you, right? It's the pilot, not the plane, right? So you have to go and learn your assessment principles that are within your profession, and then you're already learning anatomy and physiology. So now all you need to do is go take a dry needling course, which ends up being about 25 hours. It's a weekend, right? And so courses range anywhere between, I don't know, $12 to $1,500, right, per course. And then that's it. Because you've already put in the work, right? You've already studied for X number of years, and you're already qualified to assess tissue and to treat it.
Okay, thank you so much, Mr. Luna.
You're welcome.
I'm going to go, she's been staying a little longer, so I'll go her and then back to you. All right.
Hello, is it
Go ahead and
Dr.
pull it up for yourself so you don't, yeah, there you go. Yep.
Sorry. Was it Dr. Linden with Shockwave?
Yep.
I had a question about, are there any specific populations you would maybe not recommend Shockwave for, whether it's internal prosthesis or degenerative tissue disorder?
So actually you can, the only thing I would not recommend it is lack of sensation or hypersensitivity, something like that. But you can actually do it over metal implants and everything like that with no precautions. You can actually do it on pregnant women, which is crazy. You can actually even do it over the cardiac region. So there's really not a ton of contraindications when it comes to shockwave. Obviously you want to just make sure, you know, if someone is hypersensitive to any kind of sensation, you know, just make sure you go over that, start at a lower parameter and things like that. But otherwise you can pretty much use it on all aspects, which is pretty
for
nice
both
about
the
it.
superficial and the deep
Yep.
heads. Okay, thank you.
Okay, good evening, everyone. My name is Karen, and I'm currently a graduate student. I would like to know, well, first of all, thank you all so much for coming and sharing your experience and knowledge with every one of us here. My question is, can taking an amount of depressants affect the way of treatment based on the methods that you guys presented?
I'm sorry. Say it again.
One more
I
time.
didn't catch the.
My question is, can taking certain amount of antidepressants affect like the way how those methods are used in a patient?
So I would say from shockwave standpoint, there really isn't any issues with if you're on antidepressants at all. I would just make sure that you're taking a complete history and making sure there's nothing else that might outlay that treatment modality, but otherwise there's no issues with that for shockwave.
And then my second question is, do you guys, I know in medicine we keep like ethics and standards and everything, but for using those techniques, do you guys like have certain types of ethical values? I don't know how to say it, but.
So I think the coolest thing about all the modalities that we take, or just in general when we do these continuing education courses, is you're doing it on yourself with other classmates that are learning and things. So the cool thing is that we get to experience everything that we then in return do with a client. So there's a lot of times when clients might ask us, you know, what's our perspective, what was our experience? And you know, I think it's very rare that in a profession you actually undergo everything that then you do on someone else. So I think ethics-wise, you know, you have to look at your own ethics, you have to look at your own values and things when you're making these decisions. But I think it's you have a very good understanding of what your patient is experiencing.
And I think that just from a baseline, nobody has to do anything that they don't want to do, right? So that's the thing. So the beauty about all these techniques that we're presenting today is that if you possess these techniques, you have a very nice toolbox. I don't want to be needled because I heard what you said about the hypodermics and I don't care, I don't want it. Great, well let's shockwave, or let's do cryotherapy, or let's use cupping. You know what I mean? Like we can fit your treatment plan around what your preferences are.
Awesome.
To add to that point, I think it's the why. Why are you utilizing that modality versus another? Working with a lot of students, sometimes people are just like, I'm just going to do it and try it. Well, using assessment techniques like we talked about are really key to driving that why. And so like maybe it's not the right time to do it, but if we find what we want to manipulate, that's why we're going to use that certain modality. So it has to fit a certain picture versus just attempting something.
Awesome. Thank you so much.
Thank you.
Howdy.
Howdy.
My name is Madison, and I just want to thank y'all for sharing y'all's knowledge and y'all's time. I've definitely seen a majority of these modalities in my occupational therapy clinic that I've volunteered at. But my question is for Dr. Linden. When using shockwave therapy and scar management, would you say that you can use these on small muscles? And I guess would it be like a faster recovery or rehab time?
So initially, I would say, especially like post-op scar, I'll use the shockwave modality around that incision until it's completely healed. Once it's completely healed, I usually give it about 48 hours before I'll go directly over that scar itself. But after that, you can use it along that entire scar for as many sessions or treatment sessions that you need. It's just a matter of making sure when it's an open wound, obviously you're not going to use the modality right over that open wound until it's closed.
Awesome.
Yep.
Thank you.
Mm-hmm.
Go ahead.
Hi, I had a question on the dry needling. So from a therapy standpoint, a lot of the times I worked in a therapy setting, and we would often see that with certain surgeries, such as rotator cuff recovery, there's a lot of scar tissue buildup. So my question would be, can doing things like dry needling pre-surgery help a post-surgery recovery for those who are more dispositioned to?
Absolutely. So the person who is going to drive the bus in that is your physician. So once the physician gives the okay, right? Because what are we doing with the needles? When I put the needles in the tissue, the body responds by releasing substances that are going to increase blood flow, right? So think about the wilting and shriveled plant. We now bring in the blood flow into the tissue, helps to nourish it, right? And so then you take, but that's the thing, right? So if you only needle it, like that's awesome. But if you now can do exercise, that tension that's going through that network, that myofascial network, will help to guide the realignment of the collagen bundles and help to clean up your scar.
Gotcha. Thank you so much.
I have one thing to add to that too. We talk about how we alter the nervous system using dry needling, and kind of the new hotness, or one of the new hotness things, is homeostatic dry needling. And a lot of post-op patients have a ton of pain, right? And pain leads to guarding, and guarding leads to scar tissue buildup and joint adhesions and stuff like that. So there's ways to needle a patient like away from the surgical site to alter the nervous system to where they don't feel as much pain, and everything heals better when they're not in as much pain. So we do a lot of dry needling away from the surgical site just to kind of take that process for advantage, yeah.
Gotcha, thank you.
Yeah.
Thank you all for your presentations.
Can you pull it down? Thank you.
My question's for Major Carson. Is there a method that you use to motivate your active duty personnel to come and see you, or recommendations that you would give to a veteran to come and see you?
Yeah, that's a great question. So one thing I could have talked about but I didn't have time for was like the difference between kind of the collegiate setting that you guys are more used to and the active duty population. Like, I don't have control over my patient population. I can't mandate that they see me, so that's a great question. One funny thing is our commander actually mandated strength and conditioning workouts with our strength coach. So that's one way to do it. But I have found that really just building trust and rapport is key. So when I first get to a unit, I try to keep up with those guys as best I can. And I go shooting with them, I do all their fitness stuff with them, and that just buys some trust and some credibility, right? And so they're like, okay, this guy's got it, right? So then they're more likely to come see me for their injuries and things like that. And then we have success in the clinic. And I'm just honest with them, provide good care, and really that trust is kind of what I feel like really gets them in.
Thank you so much.
Yeah, thank you.
Hi there. Thank you so much for coming and sharing all your great information. My question is to Dr. Suarez about cupping. I've known for a good little while about the benefits of cupping and how great it can be for soreness and tight muscles and relieving that pain and stress off the body. And I was, a while back, had to do athletic therapy, and cupping was really great help for that. And so, like you were talking about, there are cupping kits that you can use with the manual pumps, though you can do on yourself. And I actually recently not too long ago got a set for myself, and my question is, what's your advice on like trying to learn to do it on yourself, like so you know you're not doing it wrong or you're not going to harm yourself? So what are some ways that you can learn properly how to apply it on yourself?
Yeah, so you've had the experience before, you know what it's supposed to feel like, you've kind of gone through that and they've kind of showed you that way. I would say kind of just reach out to someone and see, like, someone who's done it a lot more and say, hey, how can you show me? I always try to tell people, especially in the athletic population and in collegiate setting, hey, like, you're going to get older and you're going to leave college and you want to know how to care for yourself, and this is how you do that. So you have to set them up for success. So just going and learning from someone, showing them, hey, let me do it. Can you show me how to do it? I'm going to do it. And you recheck my work, because you're right. You don't want to harm yourself. You don't want to do something incorrectly, but you've had that experience and allowing someone to just kind of show you and guide you and then say, hey, like, can you recheck my work? Does this look sufficient enough?
So you wouldn't recommend like just trying to go online, search videos. You would try to go to someone who actually knows what they're doing.
I think there's something to say about interpersonal connection and stuff. You can see some wild stuff actually. So I was talking with a colleague at Rice the other day. I saw where they were doing dry needling on top of cupping on top of movement. So they had the needles in their arm, they were cupping, and then they were doing movement. And that was just for Instagram likes, to be quite frank with you. I think that's pretty dangerous, and I don't know if I haven't seen anything else like trying that. So I would say like that interpersonal connection is going to be most beneficial, to where you don't just go down a dark rabbit hole of oh, this is what I should do, and it might not even be from a practitioner that has done that, a lot or has that experience.
Thank you.
I do have a quick question. We'll get back to you. Stay where you are. How often does that happen? How often do you have a patient come in that has seen something on Instagram and wants to do that? I see a lot of head shaking.
So in the clinical, in the clinical setting, you see it a lot. Thankfully, what I see in the collegiate setting is, hey, should I try this? And they show me the video, and I'm like, yeah, no. Like that's not what we're gonna try. So you get it more often than not. I think like other people here can probably say some of the similar things.
I mean, you just see people WebMD diagnoses, treatments, and they come in with the most, outrageous things. Or my friend, even everybody's very unique. We have to remember that every person out here is their own individual, genetically, physically. So you might have a friend even with the same diagnosis, or used cryo or used shockwave and had a reaction, or had a good reaction or a bad reaction. Realize that, definitely realize that you're an individual, and that being said, reading on something is not necessarily going to give you that best, having a licensed professional that can sit down and go over your history and understand everything individualized towards you will make a way better option when it comes to trying to WebMD or trying to do treatments on your own.
Yeah. We have a little over 5 minutes left, so let's get to our next. Yep, you can. If we don't get you can do it at the meet and greet. So go ahead.
Howdy. My question is for Major Evan Carson. So I mentioned a toolbox of tools, and as you hinted earlier, you referenced the difference between a collegiate setting and the tactical setting. Mm-hmm. For the toolbox yourself, is there a difference between that collegiate and tactical setting for you? And if so, what tools you utilize in those differences, and how and why those apply to the tactical versus the college side?
That's a great question. The biggest difference is I'm going to weird places with these guys a lot of the time, but the tools are kind of the same. I might just take different ratios. Like I said in my talk, dry needling is my absolute go-to because of it. One, for how powerful it is, which we've talked about extensively, but its portability is great. I have a small kind of med kit that I take with me when I go to a training with the guys or go down range with them. It's primarily needles in a sharps container because it's so versatile, so portable. The blood flow restriction units are pretty small too. Those usually make it in the Pelican case and go with me. The cups are in there. I don't always pull those out, but the tools are kind of the same. It's just the portability is a huge factor when you have to kind of take your show on the road. Hopefully that answers your question.
Yeah.
Cool.
Makes sense. Thank you.
Yep.
Hi. Okay, so here's my question. So therapy has been around for a while. Despite this, it seems it has grown in popularity in recent years, and it seems more people are willing to try it out. Therefore, all these new modalities have come forward, yet there are still things to improve about each one. What is one thing you wish would be studied about your modality, and how would it benefit us in the future? And this is for all of you.
Say what is the
So
one thing?
you
Sorry,
would
come a
study-
little closer to the mic.
How would, what is one thing you would study about your modality, and how would it benefit us in the future?
There's one thing you'd study.
Well, so this talk already made me study my modality. and I'm telling you that the whole concept of everyone in here has got a latent trigger point right now, and you don't even know it's there. And then your friends call you, hey, let's go play soccer. And you're like, oh, okay, great, let's go play soccer. And then you pull a hamstring, or you pull a quad, or you strain a calf, or whatever, right? So just understanding that those little landmines are sitting there waiting to go off. So now you know that. You heard me talk today. So if you go hurt yourself, it's on you, right? So foam roll, find a tight spot that hurts, and sit on it and breathe until it doesn't hurt anymore. And then you stretch, right? So that's the thing, right? So thank you guys for making me study.
I would say for shockwave, I mean, I still think it's a very new modality because it's not in every facility. So I mean, we can look at the research and look at cellular responses, biological responses, tissue, but to actually have a better foundation of the exact time frames that ligament healing happens and how, like, yes, I can tell you from a practicality standpoint, I've seen it, but we also have added other rehabilitations and other things like that. So that makes you somewhat question and say, you know, is it just the shockwave, or is it shockwave paired with BFR, paired with therapeutic exercise? So, you know, I do think there's definitely a lot more research out there to learn about it, to get ideal numbers of, you know, can you cut a ligament healing time in half? Does this muscle fill in, you know, by using MSK ultrasound and things like that? I think there could be a lot more studies that we see in the near future.
We have time for one more question. So I know all of you probably want to answer hers, but we're going to get that last question in. So come on up.
Hello, this question's for Dr. Linden. So what is your thought process when you get an athlete that is injured? Would you let that athlete fight, or like there's a point where like, yeah, no, I don't recommend that? Because even with all those modalities, it is still a huge risk factor. I feel like the same applies with Dr. Major Carson.
I would say I'm in a very unique situation. To put things in perspective, I look at very similar to Olympic Games, our MMA athletes. Our MMA athletes only get paid if they're fighting. So, you know, a lot of times that's the only way they feed their families, they support their lifestyles. So, you know, I look at every day that they get in that octagon as their Olympic day. So it is crucial. I mean, I've had athletes that I've known of fight with fractures, fight with injuries that you guys probably would look at me and be like, wow. But I mean, number one is gonna be athlete health and safety. If there's something that's going to be catastrophic, I obviously will stick my head out and not allow that athlete to fight. But I also, because working in a combat experience, like sport, you have to be able to give and take. So I think as long as there's not a catastrophic injury happening and that injury isn't going to be impeding that athlete's success, I think the biggest thing with me is sitting down with the coaches and the athlete to say, can that injury inhibit what your game plan is? If you don't think you can go out there and win with that injury limiting you, then is it worth it? And every fight's going to be different. I mean, it might be a title fight like Francis where he literally was like, this is worth it. So I'm going to support him, use all these various modalities, and give him his best shot. So it's a very unique situation. It's definitely not your normal where you're pulling them. I try to say that I would never pull an athlete, combat athlete out of sport. I'm going to have a really adult conversation with them, their coaches, and their team, and hopefully come up with a solution that's between us all.
Thank you.
Mm-hmm. All right, well, our time is up this evening, and I want to thank all of you for coming out and spending your evening with us. I also want to give a special thank you to our Huffines staff, especially our producer, Ms. Navika Kumar, and any individual that helped make this a success. So thank them as well if you see them in their polos. And an acknowledgement to the Hilliard family. They have been extremely supportive of not only this event, but also of Huffines in general. And we encourage you to keep that discussion going. Please check out our Huffines Human Performance Minutes, our podcast, We Do the Heavy Lifting, and our YouTube channel, all of which you can access through our website, which is huffines.institute.org. And there you can also find out about being an affiliate member and our funding mechanisms. For the grad students in the audience, our research grants are due October 1st, so you have a couple days. And we don't yet have the date for HD 14. We are working on it, but we do hope that you join our mailing list so you get the announcement when it first comes out. You can join that mailing list, again, our website, huffines.institute.org, or just simply emailing us at huffines@tamu.edu. Now, those of you in the audience may not realize we've had a group on YouTube, so thank them for being here as well. And for those of you in person, we do have the meet and greet afterwards where you can talk to all of our speakers. There's some hors d'oeuvres out there. I don't know, well, I probably over-ordered, so eat them up, please. Make sure nothing goes. And my students always know I always over-order. Just have it in mind. But let's thank our speakers one last time. We would love your feedback on the event, so please scan the QR code that you see above and let us know if there's speakers you'd like to hear or topic. Thank you all for joining us. Travel home safely, stay active, stay healthy, and we'll see you next year.